This is the first module for USMLE Step 2 Clinical Knowledge Assessment, predominantly for respiratory module or respiratory system in internal medicine. It's a 10-part module, 10 questions. Each question I have split up into the question itself, the answers, and then a discussion slide about the correct answer and the wrong options, why were the options not the correct ones, and finally one slide for take-home pearls for that particular topic. Please enjoy and give your feedback in the comment section if you have any questions or any discussion points about these 10 conditions or the topics. We'll be very happy to engage. And yeah, let's start. First question. 55-year-old male comes to the clinic for a routine checkup. He has a 30-pack year smoking history. Chest X-ray shows 1.5 centimeter solitary pulmonary nodule in the right upper lobe. He has no previous imaging available. He is asymptomatic. What is the most appropriate next step in management? A. Reassurance and repeat chest X-ray in 1 year's time. B. CT scan of the chest. C. Positron emission tomography or a PET CT scan. Bronchoscopy with biopsy is D, and option number E is surgical resection. So in usual USMLE questions, you usually have up to 90 seconds to answer. So you can either pause the video at this point, think about it. And the next screen will be a 10-second timer just to give you the time before you go to the answers. So the answer for this 55-year-old male smoker with a 1.5 centimeter solitary nodule on chest X-ray, no previous films, would be a CT scan of the chest. Now let's look at the options and the explanation. So why a CT chest? Because chest X-ray on its own is insufficient to characterize, to qualify and quantify the type of nodule, its density, calcification pattern, borders, the 3D dimensions. However, if there was a previous chest X-ray, which in this case it's not, it would have helped in comparison, especially over a period of time, to see whether it is a static or an increasing lung nodular mass. So one of the gold standards, which is AU, remember our AU beetle, aurum, which stands for gold. So the gold standard here would be to use some quantifiable criteria. So Fleshner radiological criteria, if you look at the American College of Radiology Society guidelines, and any lung nodule of intermediate size of more than 8 millimeter, with the immediate next step would be a CT chest, whether it's plain or contrast, to assess the malignancy risk. Now let's look at the options A, C, and D and E. Why were they wrong? So option A, you might think, okay, if you are impulsive type 1 system, let's say the red beetle, which is a techie, the first impression would be, okay, fine, wait, because the patient is asymptomatic. However, in this situation, the waiting is dangerous because no previous X-ray to compare with. Patient is a heavy smoker, so the intermediate to high risk of malignancy will be there, especially if you look at the criteria of Mayo Clinic model for solitary pulmonary nodule malignancy risk score, which is available on different calculators. Option C again, so PET CT will be required, but it will be after the confirmation with the CT thorax. And D and E, which is bronchoscopy and surgical resection, might be needed eventually down the line, but not until the CT scan or PET CT scans are done. So remember, the option was, what is the next best investigation? So this is the clue here. Now, clinical pearl, some of the radiological patterns suggestive of the calcification patterns would indicate either a benign pattern like popcorn appearance suggestive of hematoma, laminated pattern, which is more like a layer, so that will be more of a concentric pattern, or central or diffuse pattern of calcification. So these would suggest more of a benign etiology. In terms of malignant etiology, unlike all this, if there is eccentric calcification, which is asymmetric, not diffused, if it's stippled or punctated like tiny puncta, or if it has irregular or spiculated borders, all of these features would strongly suggest possible malignant etiology, hence the need for PET CT scan, and down the line a tissue sample or biopsy would strongly be indicated. Question number 2 is based on clinical management. A 68-year-old female presenting with fever, cough, right-sided chest pain, chest X-ray shows moderate right pleural effusion. A diagnostic thoracocentesis is performed, which shows fluid analysis with a pH of 7.1, glucose of 35 milligrams per deciliters, LDH is 1200 units per liter. Gram staining is positive for gram-positive cocci. What is the best or the most appropriate next step? Options: A. Intravenous antibiotics only. B. Repeat thoracocentesis in 24 hours. C. Tube thoracostomy, which is a chest tube insertion. D. Intrapleural fibrinolytic therapy. And E. Video-assisted thoracoscopic surgery or VATS. Again, you have up to 60 to 90 seconds to decide. The next slide will be a 10-second timer only. So you can either pause the video here, carry on to the next timer, and then you can continue playing for the answers on slide number 3. So the answer to question 2, for a patient with coming in with pneumonic effusion, acidotic pH of 7.1 of the thoracocentesis tab, low glucose and positive gram stain, would be tube thoracostomy or chest tube insertion. Now, I think this should be fairly straightforward as a question, because it's a matter of pneumonic effusion or complicated pneumonic effusion, which is empyema, as characterized by acidotic pH less than 7.2. The glucose count is also low, and there is a positive gram staining or culture, or if there is visibly frank pus. If any of these criteria are present, then it's a clear indication for drainage. Remember, in our medical schools, we used to it used to be taught to us that whenever there is pus, antibiotics will not work, and the pus has to come out, because the main reason is that when there is pus, there is very poor blood circulation of that area, and the minimum inhibitory concentration, or MIC, of antibiotics will not be achieved for a therapeutic response, and hence it has to be drained, whether it's a subcutaneous pus or intracavitary. In this situation, it's a pleural space which is already devoid of blood supply, except the parietal and visceral pleura. So there is no way you can achieve antibiotic coverage at that level. So hence the pus has to come out, which means chest drain has to be inserted. In fact, even when you assess that there's frank pus, you don't even have to wait for microbiological confirmation. It has to come out. The drain has to be inserted. So that's number 1. And so option A is wrong, because antibiotics will not work. They're only indicated if the pH is above 7.2 and it's a sterile culture. Same is the fibrinolytic therapy and the VATS are not indicated in this situation. Usually those are indicated for recurrent problems, or if there is a loculated effusion and the chest tube itself is unable to drain it completely. So hence the correct option here is thoracostomy with the chest tube insertion and drainage of the pus, plus antibiotic continuation, of course. In addition to the criteria for empyema, let's just quickly look at the high yield concept of Light's criteria, which is to distinguish between exudative and transudative pleural effusions. As we know, exudative will be if there is a high content of protein. So if any of the 3 criteria are met in the pleural fluid and serum analysis or comparison, if the protein ratio of the pleural fluid to serum is more than 0.5, LDH ratio of pleural to serum ratio is above 0.6, or the pleural LDH is more than 2/3 of the upper limit of the normal serum LDH for that particular lab reference. So these are the 3 criteria. If any of them is met, then it's likely exudative effusion. For more details on the Light's criteria, dyspnea, shortness of breath, please refer to the modules in acute dyspnea series, which are already on my channel. Question number 3, a 60-year-old male intubated in ICU for severe pancreatitis complicated by ARDS. The ratio of arterial oxygen tension to inspired oxygen is 150. Chest imaging shows diffuse bilateral infiltrates. Question: which of the following ventilator strategies has been proven to decrease mortality in this patient? A. High tidal volume 10 to 12 ml per kilogram. Low tidal volume, which is 6 mils per kilogram. high PEEP, which is defined as above 20 centimeters of water, steroids, or inhaled nitric oxide. All the options A, B, C, D, E. You can pause the video up to 90 seconds or as soon as you have answered, and we will review. Answer to question 3. In a patient with pancreatitis induced ARDS and ventilator mortality benefit, the answer is B, low tidal volume 6 milliliters per kg. So let's look at the clinical reasoning for an explanation for this. Okay, this question is all about the prognostic benefit of ventilatory modalities. In patients with ARDS, the lungs are already quite stiff and heterogeneous, so that leads to increased risk of volutrauma and barotrauma due to high pressures and high volumes which overdistend the few remaining healthy alveoli. So there is a big risk. Now the evidence comes from the ARDS NET trial, which proves that lower tidal volume settings of up to 6 milliliters per kilogram of predicted body weight is specifically reduces mortality compared to the traditional volumes. So due to the same reason, the other options are incorrect. Let's look at one at a time. High PEEP, again, it might improve oxygenation by incorporating or imparting more alveoli to the oxygenation, but it has mixed mortality data, and again it can lead to more barotrauma. Nitric oxide does improve oxygenation temporarily, but has not shown to improve the survival. So remember, this question was about survival, the mortality benefit. In terms of steroids, evidence is controversial, usually not a standard mortality benefit as such. However, definitely they are used for this purpose. So clinical pearl for this question number 3 is the concept of permissive hypercapnia, which is linked with lung protective ventilation. Now, whenever there is low tidal volumes, as we were trying to achieve in this case with to aim the lung protection, obviously the patient will not be able to blow off carbon dioxide effectively, which can lead to respiratory acidosis. Yes, but as long as the pH is maintained between 7.2 and 7.25, i.e. not severe respiratory acidosis, then this is acceptable, or it is permissive hypercapnia, because the benefit of protecting the lung from physical damage it's far more important as compared to achieving a perfect arterial blood gas. So question number 4, a 22-year-old female presents with a 4-month history of dry cough, worse at night, denies any heartburn, chest X-ray is normal, spirometry is performed. Baseline FEV1 ratio FVC is 65%, while the FEV1 is 70% of the predicted best for her age, height, and sex. Post-bronchodilator FEV1 increases by 15%, which is now around 300 ml. So what is the most likely diagnosis? So this is a question about diagnosis. COPD, idiopathic pulmonary fibrosis, asthma, vocal cord dysfunction, or bronchiectasis. You can pause here. You will have up to 90 seconds. So in a patient with low FEV1 and FVC ratio suggests an obstructive etiology, and post-bronchodilator improvement by 15% is suggestive of asthma as a correct diagnosis. Okay, so this is quite an interesting question. It seems quite simple that asthma is a likely diagnosis, but let's break it down. In terms of spirometry, it clearly shows an obstructive pattern. FEV1 and FVC ratio is less than 70%. The hallmark is obviously reversibility, but remember that for reversibility, both criteria should be met. An increase in FEV1 by more than 12%, which in our patient has more than is 15% increase. And also there should be at least 200 ml increase in the absolute number in terms of the FEV1 post bronchodilator. So in this case it was 300. Yes, both are met, hence it is asthma. So remember, it's not the change in the ratio FEV1 to FVC that is already there, obstructive pattern. It's the FEV1, number one. Now, why are the other options incorrect? COPD, obviously, it will have obstructive pattern most predominantly. But it's unlikely in a 22-year-old and a non-smoker, and also there is no reversibility. I mean, it should not lead to reversibility. Usually very minimal change, less than 5% or so. unless there is an asthma COPD overlap, but that's a different topic. Idiopathic pulmonary fibrosis obviously will have a restrictive pattern, so that's totally wrong. Vocal cord dysfunction will lead to flattening of the inspiratory loop on spirometry due to extrathoracic obstruction, because vocal cords are higher up. They're at the laryngopharynx and oropharynx level, not inside the thorax. So it's more of an extrathoracic obstruction. Bronchiectasis is an interesting one. It will have predominantly an obstructive pattern, but you will not expect reversibility in this situation. So that's why the correct answer is asthma, but be careful of the criteria. Another useful clinical pearl about asthma. In case the spirometry is normal, but the clinical, like there is no change in, like it doesn't suggest an obstructive pattern, but clinical suspicion for asthma is quite high and there are no other alternate explanations, then a bronchoprovocation can be considered, unlike bronchodilation. So here we want to challenge the airways to methacholine or histamine challenge test. And if there is a more than 20% drop in FEV1, that is suggestive of airway hyperreactivity and hence asthma as a likely diagnosis. So that's an interesting question for USMLE Step 1 and Step 2 both, and also an MRCP 1 and 2. Question number 5 about management. A 70-year-old female patient is 3 days post-operative from a total knee replacement. She develops sudden onset dyspnea and pleuritic chest pain. The vitals show normal blood pressure of 125/80, but there is tachycardia at 110. Respiratory rate is 24, which indicates tachypnea, and saturations are 88% and room air, obviously quite low, especially given the tachypnea at 24. Chest X-ray is normal. ECG shows sinus tachycardia at about 110 to 115 per minute rate. What is the most appropriate next step? So this is crucial. So the choices are A, D-dimer, SA, like lab test, B, lower extremity Doppler ultrasound scan, C, CT pulmonary angiogram, D is ventilation perfusion scan, and E is intravenous heparin bolus. 90-second pause. You can pause the video or up to 90 seconds, including the next timer, and we'll come to the answer shortly. So in a patient who is post-operative, develops sudden onset of dyspnea with tachypnea, tachycardia, and hypoxia, and has a normal chest X-ray, the most likely diagnosis obviously here is acute pulmonary embolism. So what is the correct next investigator or the next step? That will be CT pulmonary angiogram. We'll come to the discussion shortly. Okay, coming to the discussion, there is no doubt that in this situation it's pulmonary embolism. So D-dimer, no D-dimer, it's a very, very common question to be considered and asked about in clinical settings. So the well scoring in this situation is already high. It's already 4 because of the surgery, tachycardia, no other alternate explanation, etc., etc. So when the scoring is high, pretest probability is there, the usefulness of D-dimer is virtually nothing. So in this situation, the correct step would be to confirm the diagnosis by appropriate imaging, which is CT pulmonary angiogram. That's why the VQ scan and Doppler are also not the correct options, because we don't have enough information to say that CTPA cannot be done and hence VQ is an alternate, or the Doppler in some situations might be a supportive investigation in case you cannot do a CT due to all the reasons, or contrast nephropathy, or if you want to avoid that complication. So that's another aspect. However, in this situation, nothing to suggest that. Heparin, you will, or low molecular weight heparin, you will only consider if there is a delay in imaging, but diagnostic imaging is the first priority. IV heparin is not the first line unless you are considering thrombolysis or a loading dose is given. Usually subcutaneous heparin, low molecular weight heparin will be the treatment of choice. So, okay, coming to the discussion for clinical pulse. So please, I have an excellent series on acute dyspnea, and I've discussed extensively about the Wells criteria, pulmonary embolism management. So please refer to those modules on my channel. However, the Wells criteria for PE, clinical scoring system to quantify the risk is based on 3 different types of points, 3 points, 1.5 and 1 point each. The 3 pointers markers are the clinical signs of DVT and PE as being the most likely diagnosis. 1.5 points each to previous history of PE or DVT, tachycardia at more than 100, and recent surgery or immobilization. while 1 point each will be for hemoptysis and history of malignancy with treatment within 6 months or palliative. Now, in terms of risk stratification, both 2-tier and 3-tier models are used. If you are using the 3-tier model, its low risk is classified as less than 2 points with 1.3% incidence of PE. Moderate risk is 2 to 6 points with a 16% increase, 16% risk of incidence of PE, and high risk is above 6 points. So in our patient, if you use a 2-tier system, it's less than 4 points or above 4. So less than 4 is considered low to moderate risk, and above 4 is moderate to high risk. So in this situation, it was above 4, so you go for a CTPA. Okay, question number 6, part 1 and part 2, like 2 slides. I really like this question, so let's read it together. A 45-year-old male presents with a 6-month history of progressive dyspnea on exertion and a non-productive cough. He reports recurrent episodes of fever, chills, and malaise that seems to occur in the evenings but resolve by the next morning. Social history: he works as a bird breeder and spends significant time cleaning cages in an enclosed aviary. He does not smoke. Physical exam includes that he is afebrile, oxygen saturation is at 94% in room air. Auscultation of the chest reveals inspiratory squeaks and fine crackles at both lung bases. No clubbing is noted. Same question 6, part 2. So investigations reveal a chest x-ray which shows diffuse micronodular infiltrates. HRCT of the chest shows ground glass opacities, centrilobular nodules, and air trapping. Pulmonary function tests confirm restrictive pattern with decreased diffusing capacity of the lungs for carbon monoxide or DLCO. And bronchoalveolar lavage shows lymphocytosis with low CD4 to CD8 ratio. The question is, what is the most likely diagnosis? A. Idiopathic pulmonary fibrosis. B. Sarcoidosis. C. Hypersensitivity pneumonitis. D. Psittacosis. And E. Silicosis. Up to 90 seconds of the time allocated, you can pause, and the next screen will be a 10-second timer as well. Answer for question 6: for a patient who is a bird breeder, recurrent fevers, has restrictive pulmonary function tests on investigations, and has a lymphocytic bronchoalveolar lavage. So the correct answer is C, hypersensitivity pneumonitis. We'll come to the discussion in the next slide. Okay, so let's come on to the discussion part of this question, which I really like. So why is it hypersensitivity pneumonitis? Because there is a clear history of exposure to birds, bird fanciers lung, due to the avian proteins. Now remember, it's an immune response to the proteins of the birds. Usually presents with acute symptoms, which are flu-like symptoms in 4 to 8 hours after exposure, but complete resolution after the exposure is over. Examination reveals inspiratory squeaks, which are high-pitched inspiratory sounds, pretty much like, think of them like a short wheezing in interstitial lung disease or hypersensitivity pneumonitis. They are differentiated from fine crackles, which are more of a non-musical crepitations, like like a crackly sounds. If you squeeze the hair close to your ears together, you can hear that rubbing sound. So that is fine crackles versus inspiratory squeak, which is at the end. HRCT shows ground glass opacities and air trapping, which is mosaic attenuation in this case. And the BAL is lymphocytic predominance with the low CD4 CD8 ratio, unlike sarcoidosis. Now, these were the yes questions as evidence in terms of the gold standard. We're talking about the AU beetle, Aurum or gold standard. Why are the other options incorrect? So option A, IPF, idiopathic pulmonary fibrosis, because it's usually chronic progressive fibrosis and honeycombing on the lungs, and usually there is no fever in older patients. In this case, it's unlikely. Sarcoidosis, again, there is no history suggestive of that. Usually you have mediastinal lymphadenopathy on CT, and high CD4 CD8 ratio, usually above 3.5. In this case, it's less than 1. Now, psittacosis might be a good differential here, because again, it's a zoonotic infection due to exposure to birds and animals. However, the diagnosis is confirmed by PCR and serology, and in this case, we don't have that evidence. Plus, it usually presents as acute atypical pneumonia rather than chronic hypersensitivity pneumonitis, as in this case. Silicosis, there is no history of mining, and it's usually a progressive lung disease, and CT findings are usually upper low pulmonary nodules and hilar mediastinal lymphadenopathy with eggshell calcification. In addition to all the discussion that we did in the previous slide, I really love this clinical concept, and it's a very useful information for any step 1, step 2 questions, whether it's USMLE or MRCP. The CD4-CD8 ratio in BAL, in bronchoalveolar lavage. So it usually differentiates between the different types of ILD. So in sarcoidosis, the ratio is usually above 2. So 2 to 4 is the usual ratio. And that's because the CD4 cells, CD4 plus cells, they of the T cell subtype, they drive the granulomas. While in hypersensitivity pneumonitis, it's basically the CD8 plus cells which drive the reaction, the immune reaction. So the ratio is low in hypersensitivity pneumonitis. So CD4 to 8 ratio will be high in sarcoidosis and low in hypersensitivity pneumonitis. Okay, so question number 7 is about anatomical identification of the lesion. 64-year-old male presenting with a 2-month history of right shoulder pain radiating to the inner arm and hand. He reports drooping of his right eyelid and lack of sweating on the right side of his face. Clinical examination shows ptosis and meiosis of the right eye, and there is weakness and atrophy of the right hand muscles. What is the most likely location of the primary tumor? So this is a 2-part question. First you have to think of the diagnosis, then you think about the question or the stem. So the stem is about the location of the tumor on the right side. A, is it the right lung hilum? B, is it superior sulcus, which is the right apex of the lung? Is it the right mediastinum? Is it cervical spine, or is it the pleural base? 90-second timer, including the next slide. You can pause, think, and then we'll come to the diagnosis and discussion. So a patient with shoulder arm pain, Horner syndrome, which is indicative suggested by ptosis, meiosis, and anhydrosis on the ipsilateral side, and hand weakness of small muscles on the same side. No doubt that it's Pancoast tumor. So what's the location? It's the superior sulcus, which is the apex of the right lung. So explanation, there is no doubt that it's a Pancoast tumor. Tumors in the superior sulcus or the apex of the lung can lead to damage to the inferior roots or the trunk. So if the lung tumor is here on the right apex, remember from the brachial plexus anatomy, you've got roots, trunks, divisions, cords, and branches. So the roots are C5, C6 are the superior, C7 is the middle. C5 and C6 lead to the superior trunk, the C7 goes as the middle trunk, and the C8 and T1, the lower nerve roots, they form the inferior trunk. Eventually, the same C8, T1 goes as an ulnar nerve after the divisions and cords. So, any damage to the inferior roots like C8 and T1 or inferior trunk will lead to the damage or to the distribution of the nerves C8 and T1. So again, shoulder pain radiating to the ulnar distribution, which is so remember C5, C6, C7 is the middle finger, C8 and T1 are the lateral, the medial 2 fingers. So the little and the ring finger. So 3.5, 1.5 distribution, the median nerve, and then you've got 1.5 of the ulnar nerve, if you remember. So any damage to this part will lead to hand muscle palsy, which is called the Klumpke's-like palsy. Same as stellate ganglion, damage to the sympathetic chain here in the thoracic part will lead to the Horner syndrome. So that's an autonomic response of ptosis, meiosis, and anhydrosis. So why are the other options incorrect? So hilum A is because the hilar lesions lead to superior vena cava syndrome, so facial congestion and all the Pemberton signs and all those bronchial obstruction, not brachial plexus involvement, because it's the hilum, not the brachial plexus. Cervical spine, again, it can lead to cervical radiculopathy, but unlikely to cause Horner syndrome because the cervical spine is at the back and the stellate ganglion is located anteriorly. So and also it's unlikely to cause Horner syndrome, as you said, and also weight loss will be obvious in such situations. In terms of the other options, again, pleural base and mediastinum for the same reason, the anatomy is not right. Just another quick exam tip about the histology of Pancoast tumors. You might come across a question in step 1 or step 2. So remember that most Pancoast tumors are usually non-small cell lung cancers. And squamous cell carcinoma is the most common subtype associated with this presentation, and it tends to arise centrally and apically and invades locally rather than metastasizing early. So this is one of the key learning points from exam tips. Okay, question number 8. A 25-year-old male with cystic fibrosis presents with worsening cough and brown tinged sputum. He has been using bronchodilators more frequently. The labs show eosinophilia at 1200 per microliters, and total IgE is markedly elevated at 1500 international units per ml. Chest X-ray shows fleeting upper lobe infiltrates and gloved finger shadows. Which test confirms the diagnosis? So it's a two-part question. So the options are A, sweat chloride test, B, sputum for Pseudomonas, C, Aspergillus specific IgE/IgG, D, bronchoscopy, and E, serum A180, which is alpha-1 antitrypsin levels. 90 seconds timer. Please pause and then we'll proceed. So the correct answer for this patient with cystic fibrosis and asthma history, brown sputum, high IgE and eosinophilia, and gloved finger shadows on chest X-ray is Aspergillus specific IgE/IgG. Now this is again an excellent question. Honestly, I like it for many reasons. Let's go through. Okay, so what is the diagnosis? In this patient with a history of cystic fibrosis/asthma, infective respiratory symptoms, brown sputum, he has got high IgE, eosinophilia, etc., etc. So the diagnosis obviously is allergic bronchopulmonary aspergillosis. Why do we say that? Because it's a hypersensitivity reaction to the Aspergillus fungus, and it's seen predominantly in asthma cystic fibrosis patients because they've got colonization and immunosuppression. The classical triad is exacerbation of asthma/CF plus recurrent fleeting infiltrates and bronchiectasis, which is more central. Diagnostic clues are high IgE, peripheral eosinophilia, brown mucus plugs. The chest X-ray is not pathognomonic but suggestive because the gloved finger appearance means there is mucus plugging, the mucus secretions distal to the bronchioles, the terminal bronchioles. They are engorged and thick, and hence it leads to the gloved finger appearance. Okay, now let's look at the negatives. Why do we say that the rest are not possible? So number one, I think the option A and option E are a very good red herring sign. So sweat chloride test, whenever you think as a student or as a doctor, when you're appearing in exams, when you think of cystic fibrosis, the first thing comes into mind is, oh, sweat chloride test. We don't need it because it's already confirmed diagnosis, so that's out. Serum alpha-1 antitrypsin, option E, again, this is for emphysema. So usually cystic fibrosis/emphysema, there is always a confusion. So remember, cystic fibrosis is, or bronchiectasis is, which is usually a spectrum. So if there is a dilatation of the bronchioles proximal to the terminal bronchiole, that is bronchiectasis. So bronchiectasis, ectasia dilatation. And distal to the terminal bronchiole is emphysema. So in this situation, we're not considering emphysema as a diagnosis. Now, Pseudomonas, yes, you might require sputum cultures because of the heavy risk of colonization, but it doesn't cause high IgE or fleeting infiltrates. Bronchoscopy may be considered down the line, but not as first line. And again, because the diagnosis mainly is serological. So if you can get a diagnosis with a sputum sample and ABPA serological testing, that should do rather than going for invasive bronchoscopy. However, if the diagnosis is not confirmed or if the patient still does not continue to improve, then bronch with a BAL and cultures will definitely be indicated. When we have discussed about ABPA, let's just quickly go through the clinical pearl about quick management tips. So what's the goal in ABPA, allergic bronchopulmonary aspergillosis, which is to suppress the immune reaction and also to reduce the fungal burden. So it's a two-pronged approach. So to suppress immune reaction, you need systemic steroids in terms of prednisolone, usually given for several weeks because it will take time for clearance or for suppression of immune reaction. And adjunct antifungal would be itraconazole to decrease the fungal load, and now also it will help taper off the doses of steroids. Again, long-term steroid use, please remember to consider the stomach protection in terms of PPI and bone protection in terms of supplemental calcium and vitamin D. How do we monitor? We monitor based on the total IgE level response and serial monitoring. Usually it's done by a pulmonology team as an outpatient in the clinics, but the serum IgE levels should be monitored and they should drop with the subsequent treatment. Question number 9, two-part question, part 1, like a first screen. A 50-year-old male with 2-week history of fever, night sweats, weight loss, and foul-smelling sputum. He has a history of alcohol use disorder and was found unconscious on the street 3 weeks ago. He has poor dentition. Chest X-ray shows a cavity with an air fluid level in the right upper zone. So question 9 continued. So he is admitted to hospital and the hospital course suggests that he was started on antibiotics. The question is, which of the following antibiotic regimes is the most appropriate empirical therapy? So again, it's a two-part question. You have to think of the diagnosis and then think of the treatment modality. So the 5 options are A, metronidazole alone, B, ampicillin sulbactam, C, ceftriaxone plus azithromycin, D, vancomycin, and D, E is levofloxacin. So again, up to 60-second timer, you can pause the video and then we will come to the discussion. So the answer to question 9, for a patient with history of alcoholism, foul sputum, poor dentition, and a cavity-filled air fluid level on the chest X-ray suggestive of lung abscess, the options of antibiotic ideal one will be ampicillin sulbactam, option B. So let's come to the explanation. There is no doubt we are dealing with a patient who has lung abscess, most likely due to aspiration, and the risk factors are already there. History of alcohol ingestion, intake, poor dentition, which leads to higher anaerobic load. The pathogens, usually it's polymicrobial, but oral anaerobes like Peptostreptococcus and Fusobacterium plus aerobes as well. These can be contributing pathogens. Treatment needs antibiotic coverage which has sufficient anaerobic coverage as well. So ampicillin sulbactam, unison or carbapenems are first line. Clindamycin is also an alternative. Now, why are the other options incorrect? So metronidazole alone, again, it has a decent and anaerobic coverage, but it has poor lung penetration. For GI infections, gastrointestinal infections, yes, metro is still considered in addition to vancomycin, but poor lung penetration, and hence it's a high failure rate when used alone for lung abscesses. Ceftriaxone and azithro in combination, you would consider standard community-acquired pneumonia coverage in most parts of the world, but they lack anaerobic activity individually. Same is for options D and E. Vancomycin, it has a decent gram-positive anaerobic coverage, but lacks gram-negative anaerobic coverage. And levofloxacin again has a very intermediate type of activity, but not a proper anaerobic coverage at all. So the best option is ampicillin sulbactam. So the key learning points for this aspiration pneumonia, it's a beautiful slide actually. So gravity will dictate the aspiration pneumonia and the abscess formation and the risks. So we all know that the anatomy of the trachea and the bronchi is the right main bronchus is straighter and the left main bronchus deviates at an angle. So it's difficult for the secretions to navigate that acute angle to the left, and hence the most likely site of aspiration usually is the right side, the right lung. Now again, in the right lung, it depends upon the position. So if the patient is more supine, so bedbound, chronic, bedbound patients, elderly, frail, low GCS, or patients with history of alcoholism, then the location of the aspiration usually is, obviously on a chest X-ray, it's very difficult to say which lobe because you're only seeing the zones, upper zones, middle zone, lower zone. But in terms of anatomy, it's usually either the right upper lobe and hence the posterior segment, the deeper segment, which is more towards the gravity. So this posterior segment of the right upper lobe, or superior segment of the right lower lobe. So the right lower lobe is curving behind, and the superior segment we are talking about. While in patients who are more upright, like sitting or standing, and usually if there is a vomiting and they've aspirated, then you're talking about the gravitation of the secretions right down to the lower part of the right lung, and hence the basal segments of the right lower lobe will be involved. So the shadowing on the chest X-ray and the location can give you a clue, or the history can give you a clue. So either way, clinical reasoning really important in this situation. Okay, so the last question of this module, question number 10, it's about diagnosis. A 32-year-old female presents with progressive dyspnea on exertion over 1 year. She reports occasional chest pain and fainting spells, and she takes no medications. On clinical examination, there is a loud P2 component of the second heart sound, and there is mild right ventricular heave. The lungs are clear to auscultation. Chest X-ray shows clear lung fields with prominent central pulmonary arteries. The question is, what is the definitive diagnostic test? Is it A, transthoracic echocardiography, B, high-resolution CT of the chest, C, right heart catheterization, D, VQ scan, or E, pulmonary function tests? So you can pause the video for up to 60 to 90 seconds, and I'll get my med ed trio, the techie, ready, and the AU, the gold standard, and we'll come to the discussion in a moment. So what's the answer for this question 10? A young female with history of progressive dyspnea, loud P2 and right ventricular heave on examination, and has clear lungs on auscultation as well as chest X-ray. So the answer is right heart catheterization. We will come to the discussion shortly. Okay, so for the final question number 10, we will be using the med-ed trio. So when you read the question, obviously the first thing which comes to mind, yeah, this is pulmonary hypertension, but okay, transthoracic echocardiography. So that's the instinctive response of the system 1, the fast one. So techie beetle will be thinking, yeah, this is it. But then hang on, you've got the Brady, the green turtle, who is system 2, thinks about it. So if you read the question again and the final step, so this is where the exam savvy and exam smartness comes to play. So the question was, what is the definitive diagnostic test? It did not ask what is the next best step. So that's why reading the stem plus the final part of the stem or the question is really crucial. So in this situation, there is no doubt there is pulmonary hypertension. So let's look at it. So why? Okay, clinical picture. Why is it suggestive of pulmonary hypertension? Because the patient is young, female, has got clear lungs on auscultation as well as chest X-ray, which excludes the respiratory or the lung etiology. So most likely it's group 1 pulmonary hypertension or pulmonary arterial hypertension. We will come to that in the next slide. So diagnosis, echo is definitely the best screening, but right heart caths, which is a definitive gold standard, which brings us to the AU. AU is aurum is gold. So the gold standard or beetle, this gives you the definitive diagnosis. So it's mandatory, the right heart cath is mandatory to measure the mean pulmonary arterial pressure. If it's above 20 millimeters of mercury, then that is confirmatory for pulmonary arterial hypertension. And also you measure the wedge pressure as well. Let's look at the incorrect options. So option number 1 is echocardiography. Obviously we said it's for screening but not the definitive diagnostic test. Then we have HRCT, that's to look for the lung parenchyma, but you're not suspecting any lung issues as such. VQ scan and CT pulmonary angiogram, again you would be thinking of the chronic thromboembolic pulmonary hypertension, which is group 4, but not a gold standard for pressure measurement. So it gives you indirect evidence of the etiologies but not the definitive diagnosis itself. And lastly, let's look at a brief pulmonary hypertension classification simplified. So there are 5 groups. So group 1 pulmonary arterial hypertension is idiopathic or connective tissue disease. Usually the mean arterial, the pulmonary artery pressure is above 20 and wedge pressure is less than 15. Group 2 is related to the heart. So left heart etiology, heart failure, valvular disease. Again, the pulmonary artery pressure will be above 20, but the wedge pressure will also be high, more than 15. That's the post-capillary one. Group 3, we are talking about the lung as an etiology. So anything to do with the lung parenchyma, COPD, interstitial lung disease, sleep apnea. Again, it's due to hypoxia, chronic hypoxia or hypoxemia, which leads to vasoconstriction over a period of time that leads to pulmonary hypertension. Group 4 is chronic thromboembolic pulmonary hypertension, and that's due to the chronic PEs, and hence vascular pressures will be increased gradually over a period of time. Group 5 is idiopathic or unclear cause, when there is uncertain etiology. Multifactorial mechanisms could be blood disorders, metabolic disorders, sarcoidosis, so again various mechanisms. So it's important to understand that group 1 is predominantly the one which responds to the vasodilators like sildenafil and bosentan.